Yeah, thank you all. That was just fabulous. I will tell you, I love, for many of the MD specialties, there's a lot of solo activity, but as the rehab team, we really come as a team, and you see we combine all of our skills together to really maximize an individual that really has complex problems. So I would like to open up any questions from the audience. Dr. Volpe? Yeah, that's fine. You want me to read these? Yes. Okay. What outcome measures do you find most useful for OT and PT in the hospital for your stroke patients? What outcome measures? PT, OT? I guess the question would be for short-term benefit or long-term, right? It kind of depends on how you answer that.
So I can answer for physical therapy. So the Academy of Neurologic Physical Therapy actually has guidelines on which outcome measures are most beneficial. They kind of break it down into just general neurodiagnoses, and then you can also look at stroke. So there's just a vast variety. Some of the most frequent ones that I personally will use will be the Berg Balance Test, the Orpington Prognostic Scale. We do use the MRS, we do a baseline, and then we do what their current functional status is when we evaluate them, as well as at every treatment session. Trying to think of what other ones. Those are probably the most frequent ones. There's also the Dynamic Gait Index, TENETI. Judy, any for OT that you guys use?
Well, I currently use the PASS, which is the Postural Assessment Scale for stroke. Works great, looks at a lot of balance, but most importantly in acute care, we're looking at getting a patient in and out of the bed and to the bathroom and to the sink, to the chair to be able to eat, so we use that. Physical therapy folks are using the Orpington as well. It looks at some cognition, as well as some other aspects of self-care. Functional reach, I was jotting down a couple. We also use the Barthel, modified Barthel index for ADLs. I use the grip strength, I like that one. It really looks good both for upper extremity strength. We can use it a lot when we have those neurologic functional dysfunction folks. And we can do some comparative information for stroke patients, so that works well there.
And then I was going to say for speech, if I can add a question, is how, the fees has been relatively new. I mean, that's been initiated since I've been here, and in recent years. The modified, I think, to your point, everyone was trained in it, and it was the gold standard, and we're used to using it. It's a very labor-intensive test, so once you've trained to use it, you feel comfortable with it. So how important has it been to you to add fees as part of your tools for being able to evaluate dysphagia in the acute care setting?
Yeah, let's see. It's been really useful, especially in the ICU level of care. If a patient requires oral intubation and we have concerns for secretion management, vocal fold pathology, on top of their new neurological deficits, it really kind of opens up a whole new window of evaluation that we might not be able to see with the modified Braham Swallow study.
Yeah, and I think the other part, just to add, is for a modified patient has to be able to sit, and they have to go down to radiology, and a lot of our folks just aren't there yet, so the fees really gives us some good data at the bedside. So it's been a really nice tool to add. I would recommend that be, kind of standard for stroke care for folks who look after stroke. What is this will be for PT, for therapy for also, what is your protocol or timeline regarding initiation of PT following TPA?
So currently we do 12 hours. We're also assessing vitals and just the overall patient neurological status, just to make sure that there are no other issues going on with the patient. But our hard and fast is 12 hours, and then we'll return patients back to bed until they get to that 24 hours, and then we'll kind of resume our usual therapy, usual care after that.
Anyone else? Any additional questions for us? Dr. Volpe.
Judy, I think one of the things you said was you start out by asking what's your exercise program, what do you do before all this? And if you think about how important it is for a lot of people to have an exercise class or exercise friends or things like that, with disability, where do you send somebody for an exercise class? What's out there? Because a lot of the Peloton's not going to be there, the other things aren't going to be there. But what can people who are disabled connect with in that regard?
There are some great resources. The YMCA has some great resources. The Jewish Community Center. Now, COVID put a big squash on a lot of those. And so when we had patients who would come in and they were asking, well, where can I do these exercises? One, we immediately give information in regard to doing just some home exercises, arm exercises, leg exercises that they can do. There's a great article that just came out. I cannot quote it right now, but I've been talking with other colleagues about it in regard to actually putting home range of motion exercises in the ED, so that when a patient comes to the ED with stroke-like symptoms, and maybe they don't come to the stroke floor, but they need some information about where can they go and do exercises, what exercises can they do. And there's really some great research that says if you provide these exercises in the ED, these folks actually are going forward with that. A lot of times I tell people just to walk. If you don't do anything, do 8 laps around your island in your kitchen just for some exercise. Functional activity is the key. Repetition is the key. Walk to and from the bathroom, fold some towels. All that is exercise. Play cards, play bridge, just typical tasks like that. If we could get them involved in doing some of the computer games, that would be wonderful. And that's not everyone's cup of tea, but it's amazing to watch these older adults on their cell phones. So if we could cue them into some YouTube videos for some exercises on their phones, that would be wonderful.
Yeah, I was going to say there's always been Sit and Be Fit. It was on the TV showing modified chair, chair level exercises. In Houston we have the West Gray Multipurpose Center. I don't know if they reopened after, but they had been a good resource for our patients. But I think, Dr. Volpe, one of the things I spend time with my folks is figuring out what motivates people. So if folks, you can teach them and they do it by themselves, that's just fine. And there's folks who need an exercise buddy, and then there's folks who need an exercise class, and there's folks who need a personal trainer or some accountability partner. So we actually, as professionals, spend time figuring out what that is and then discuss the maintenance. The maintenance therapy is key. And figuring it out while you're in an active therapy session, kind of how they're going to follow through. One of the other things, and this was across all discipline, that we still struggle with, unlike our colleagues that have pharmacological treatment, is what is the right dose of exercise? There really, I will tell you, across PT, OT, speech, do we do it 1 time a day, 4 times a day, 6 times a week, 4 times in a month? Like, what is the right dose intensity? Hopefully over time we'll get more of that, but since most of our treatment after stroke is targeted on function, I think to really reinforce Judy, is you just get them back into do what you want to do in your daily life. If that's putting puzzles together, if that's reading, if that's gardening, if that's walking, if it's playing with the grandkids, do those activities to get good at those activities.
I do think some of the concern comes in with some of the patients who come in with a dissection, though, and we talk about what extreme exercises they do. So I ask that question, what exercise program do you do? Generally when they have, and I haven't seen necessary specific research, so if anybody wants to comment on this, but some of the dissections are due to some extreme exercises that they're doing in the gym area. And so we'll have a little bit of conversation about healing and then letting them talk to their neurologist when they should resume more heavy lifting type exercise.
And we are tight on time, so there's a great question about VR. I don't know if you can tackle it very quickly about 1 person, 2 person, and how easy it is.
Sure. So I think you need to take into account how the patient presents with their deficits. So if it is somebody that is able to ambulate independently or needs a little bit of assistance, it also depends if you're doing the virtual reality in person, because then as a physical therapist, I would feel comfortable being able to guard this patient because I could anticipate some of the strategies, hip strategies, ankle strategies, stepping reactions that this person might have if I'm doing something like the Connect or the Wii or something like that, which are where a lot of the research has been. And actually they use the Xbox Connect in that one study that I presented earlier. In terms of needing a second person, I think it just depends on what you're trying to accomplish. There's also a lot of research that comes out with upper extremity as well, so you wouldn't necessarily need a second person for that, but take into account like everyone has been stating, the overall picture, what's your goal. So doing this by itself may not be beneficial, but in addition to just conventional therapy, then maybe we're looking at improving outcomes. So I wouldn't necessarily just look at VR and do that by itself.
All right, thank you.
Thank you guys so much for